This is a case of a young male patient with history of multiple vitreoretinal surgeries resulting in a complicated and partially absorbed cataract with fibrotic and stuck down anterior and posterior capsules, as you can see here. In such a case, the most important step to determine the patient's vision outcomes would be a well-centered capsular opening with a stable intraocular lens, and presently my only indication for a femtosecond laser is a more predictable capsular access in such cases. So I applied the femtosecond laser using areas of separated capsules in the maximum potential spaces, and yet it miserably failed, leaving me in a more precarious situation of certain cut areas of the capsule in an already difficult situation. So I moved this patient to the surgical microscope and start making a manual plan as I go. I stained the capsule, trying to make sure for future visibility and maneuvers. I exchange the air bubble now with the viscoelastic. Now I go in with a cystitome, trying to find my edge for making an anterior capsular access. Here I am gingerly and carefully looking, and I even used viscoelastic to separate the leaflets of anterior and posterior capsule in any potential area I could. Not many, as you can see. Slowly, using patience, I do find an edge of anterior capsular opening with my cystitome, and I start using the uterata, pulling it around in a capsular access fashion. And I feel happy and more confident as I go, making a nice circle, even though I feel differential tensions of fibrotic areas and stuck down areas between an anterior and posterior capsules. My biggest aim here being not to radialize the tear or damage the posterior capsule. I now use a Drysdale to separate the leaflets and loosen some cortical material if I can. Now going in with the irrigation aspiration, I try and get some loose cortex, and I'm not so bothered about the fibrotic periphery. Now I examine the posterior capsule and I see over here extensive fibrosis and also a definite area of opening. So I must make a posterior capsular access, and I think how. Once again, I look for areas of little more approachable capsule, and I start with the cystitome, going in an opposite direction of capsular access from my usual maneuvers, and I'm gratified to see a nice circular access coming about. Once again, I feel the fibrosis, and I do not want radialization or damage to the capsule, which may lose my only support and this patient's hope for excellent 20/20 vision. As I come full forward towards my rhexis, I do see this area of extensive fibrosis, and as I tug on this area, you can see the intense strength of this fibrotic area of the capsule. So I determined now to use an intraocular micro scissors to cut this fibrotic area, not damaging the edge of the rhexis though. And then I use the fag end of this fibrotic area to pull on the rhexis and complete my posterior capsular access. Feeling confident now, I'm injecting my intraocular lens gently more to the side in the eye, and then I will move it to the center like so on my platform of the capsular access leaflets, dialing it into position into the sulcus. Now I gently help the optic get trapped with the capsular access edges and feel even better as I feel a secure capsular bag with good zonular support. We can see the ovalization of the capsular bag edges, and here I am testing the platform and feeling nice and confident about good centration and central clarity for this patient's vision. Using irrigation aspiration, I remove the viscoelastic and also try for any more residual cortex, not bothering about the peripheral fibrosis, which could be helpful to us. The self-sealing incision is now further strengthened using the ReStor sealant. And here I am removing the excess sealant to prevent any irritation or foreign body sensation. So what is important in this case is not only the fact that we were faced with a challenging situation and had to make our plan as we went, but the desire to not give up on our 20/20 goal is very, very important. And you see here this patient next day post-op comfortable and 20/20. Thank you.